Good afternoon. I'm Marcus Jones, Charlotte City Manager, and I'm here today with our Mayor, Vi Lyles, and Council Member Larkin Eggleston to talk with you about what's something that I believe is very exciting, a partnership with the city and Atrium Health. For the last year and a half, we have been looking at violence through a public health and evidence-based solution lens. And today is a culmination of a lot of hard work to get us to a point when we look at violence that is just not a police effort, but we want to engage the entire community and look at this as an equity, opportunity, and safety plan that is a part of our Safe Charlotte plan. So with that said, I will turn it over to the Mayor.
Thank you, Mr. Jones. I want to follow up on the city manager's comments, but I also want to speak from both my heart and my head about this issue. We all know that we are experiencing a community crisis. We know that it takes a commitment from the city and our partners and every person that lives inside of our community to address this crisis. There have been too many incidents of violence in our city, and we must be fully invested in finding a solution to this problem. It's clear from data and case studies, research in other cities, that this is not going to be easy. And there's not a cure-all that one person can say, if you do this, it will be gone. It's not going to go away without all of us. The social factors involved in violent crime are extremely complex, long-standing, and so our response must be equally comprehensive and long-standing. Today's partnership with Atrium Health is another violence prevention tool that's being added to the work that has been done by the Safe Communities Committee of the Charlotte City Council, and it is part of what I would call our toolbox for change. We actually started this work last year, working with specialists to develop an evidence-based strategy that would have great impact. I know that Atrium joins us in the passion that we have for what we can accomplish together. Atrium has a tremendous track record in what they're doing at Carolinas Medical Center, the only level 1 trauma center in our region. So Atrium was an obvious choice, one that the City Council first considered as a core for our first program last summer. Personally, I have great hope that this will produce real results, that we can begin to drop the cycle of violence from our lifestyles and show the victims and our families that there are other ways to solve disputes. Atrium will be giving the City Council regular reports on the effectiveness of this program, and we plan to take that data that they collect to support our overall efforts to make Charlotte a safer place to live. I want to thank Atrium for stepping up and joining us in this effort. I'm going to ask Dr. David Jacobs, who has worked in violence prevention and reduction with our CMPD, and who has years of experience in equity around this effort, to welcome him and say thank you for being the person, the doctor who will be leading the Atrium experience. Dr. David Jacobs, please step forward virtually.
Good afternoon, Mayor Lyles. Thanks for having us. We are thrilled to be partnering with the City of Charlotte to establish a hospital-based violence intervention program at Atrium Health here in Charlotte. We know that for hospitalized victims of violence, chances of becoming a repeat victim or even a perpetrator of violence can be as high as 40%. A study performed at our own level 1 trauma center here at Atrium Health puts that figure at 25%. In other words, a 1 in 4 chance of becoming re-engaged in violence if nothing is 1 in 4 chances by providing intensive 24/7, 365 case management services, starting in the emergency department and continuing in many cases for weeks and months beyond hospital discharge. These programs have been proven to reduce future violent re-engagement and criminal involvement, improve the self-esteem and self-sufficiency of violence victims, and even save money, both for the healthcare system as well as for the larger community. There are approximately 40 such programs throughout the country, but none in North Carolina. And so we are excited and proud at Atrium Health to be the first hospital-based violence intervention program established within our state. We want to point out that our hospital-based program is but a small, although significant, component of a comprehensive, region-wide violence reduction plan. Part of that plan involves bringing the Cure Violence model of community violence reduction to Charlotte. We believe that there are significant synergies between our hospital-based approach and Cure Violence's community-based approach, and we look forward to working closely with them to reduce violence in Charlotte-Mecklenburg. We also want to echo the mayor's words of caution that neither of these programs is an overnight fix, and that sustained reductions in violence will take time and will take patience. Finally, we also want to echo the mayor's words and remind everyone that even though the city is investing heavily and wisely in violence prevention, that this investment alone will not get us where we want to be. Violence anywhere in our community where we live, and so we all have a role to play in preventing it. This is where I think the newly created Office of Violence Prevention can help give us a sense of common purpose, leverage our unique strengths and skill sets, and connect us to the important work already occurring in our communities. Now I'd like to turn it over to Councilmember Eggleston, Chair of the city's Safe Communities Committee. Thank you.
Thank you, Dr. Jacobs. As Dr. Jacobs said, this is going to be a first-of-its-kind program in the state. We know the violence that our city has been facing in recent years is something that is complicated and is going to require a multi-pronged approach to address. So this program with Atrium, as you said, first of its kind in the state, and we think will be very complementary to the work we're doing with Cure Violence and in a lot of other areas to address violence. The numbers that he stated in terms of the recidivism we see with people who come into our hospital system seeking physical help for the injuries they sustain as a byproduct of a violent encounter, we want to make sure that that's the last time that they have to come in there and be treated for those kind of injuries. We want to make sure that we're addressing the cause of those sort of injuries and that we're preventing them from becoming part of a cycle where this happens again and again. We want to help both the victim of these encounters, but also the abuser. We want to be able to intervene in these situations to make sure that this violence doesn't perpetuate itself. As was stated, almost half of the people who come into the hospital system with this sort of an injury or from this sort of a situation are likely to be back in that situation within 5 years. So we think this is a way to change the trajectory of that person's life and change the trajectory of any future encounters that they might have with an abuser or with someone that they have a conflict with. So we really want to be, we are very thankful to Atrium for being our partner in this effort. We're very thankful for the community for embracing some different solutions that the city of Charlotte has identified for addressing a problem that I think we all understand has to be one of our top priorities. With that, I want to turn it back over to the city manager, but just reiterate to the people of Charlotte that this is something that we are taking very seriously. We are looking for new solutions for. We are committed to addressing and improving the outcomes that people in our community will have when it relates to violent crime.
Thank you, Mayor. Thank you, Councilmember Eggleston, and thank you for our partnership with Atrium Health. So at this time, we will open it up for questions, and I believe Corey will be conducting the questions and responses. Thank you.
Thank you, Mr. Jones. A reminder to our reporters, if you will raise your hand in WebEx, we'll call on you in the order in which you do that. And our first question this afternoon will go to Hunter Sines.
Hi there, everyone. Thanks for holding this news conference today on a very important issue in our community. I did just want to ask, this could be for probably Dr. Jacobs, but how exactly will this work for our viewers who are tuning in today? If somebody is shot and brought into the ED and is treated, let's say for a gunshot wound, what kind of services exactly are you talking about to help prevent them from coming back in? How will this look?
Well, thank you for that question. As I said, there are many similar programs across the country, but each program has to be based upon the resources that are available in that community. And so we will have a violence intervention specialist available 24/7, 365 to immediately respond to the emergency department. Keep in mind, a lot of these patients will be discharged from the emergency department. So unless that initial contact is made while that patient is in the emergency department, we have lost that opportunity. And so we will first assess how that patient got into the position of becoming a violence victim, what were the risk factors, then also obtain an inventory of what protective factors that patient has in the community, what services we can offer. That could be anything from gang de-involvement, tattoo removal, help with legal problems, help with education, job training, whatever it takes to fortify that individual's environment so that they will not become a victim of violence again. Every patient is going to be different. Every patient is going to have different needs. And so we tailor the intervention to the specific needs of the patients. And that, again, may require intervention that goes on for weeks and months, in some cases a year after the patient has been injured, to be sure that that patient has everything they need.
Thank you, Dr. Jacobs. And Hunter, thank you for identifying Dr. Jacobs as the recipient of your question. Just a quick request to our reporters, since we do have 4 speakers as part of this event today, we would ask that you identify the individual that your question is directed to. And with that, we'll turn it over to Brett Jensen.
Thanks, guys. Sorry about that. Corey, you and I were counter-muting each other. This is going to be for Councilman Eggleston and for Dr. Jacobs. I'm not sure which one of you will be able to answer this, but I think one of you will be able to. In terms of doing this, will this actually help prevent the murder rate? As we know, we just set an all-time record for the number of murderers. Or is this more of a domestic violence situation or a gang situation? What areas, because I'm sure you guys have looked at the other 40 cities that you talked about doing this, what areas specifically do we expect to see the biggest decrease in?
Well, I'll let Dr. Jacobs speak to where he thinks the most significant statistical impacts will be, but I think to your question of which of these things will it address, I think it's all of the above. A study was done along these lines in Baltimore where they saw statistical impacts in decreasing the amount of violent crime in their community. And the statistics that Dr. Jacob mentioned earlier reference that someone who is a victim of these kinds of crimes or this kind of violence, it increases the likelihood that somewhere down the line in the not too distant future, it increases the chance that they will die from this kind of violence. So I do think that it can work very directly to lower the murder numbers that we're seeing in our community. And I think it addresses all of the different types of crimes or things that might lead to violence that you mentioned. Dr. Jacobs might be able to speak better to if he thinks one of those might stand above the rest in terms of the impact we'll see.
We do a better job with intimate partner violence. That's been recognized, and there are teams that specifically address that particular form of violence. There are teams that address specific forms of child abuse. But we know from national statistics that youth violence, and when I say youth, that's really defined between the ages of 10 and 24, that's really the area of maximum violence involvement. And so although we'll be looking at all ages, I suspect most of our clients will be in that younger, sort of older adolescent, 20s, early 30s age category. Let me also remind everyone that even though we focus on mortality, we focus on the number of folks who die, that's just the tip of the iceberg. It's easy to measure when someone dies, unfortunately. They either die or they don't. But the estimates are that for every death that occurs as a result of interpersonal violence, there may be as many as 99 additional incidents that are non-fatal. And so our goal is to reduce violence, clearly reduce deaths, but also reduce all of the other non-fatal violent interactions. I've always said over here at the hospital that the only difference between somebody who dies, somebody who gets seen in the emergency department and sent home, and somebody who gets admitted to the hospital, the only difference is aim. If I shoot you in the leg, you're likely to be discharged from the emergency department. If I shoot you in the chest or in the head, you're going to require admission to the hospital. That doesn't mean that you're at any lesser risk of being readmitted to the hospital. So we view all of those incidents, fatal, non-fatal, admitted to the hospital, not admitted to the hospital, we view all of those incidents as serious and worthy of violence intervention.
Okay, before we get to Joe Bruno for our next question and Brett Jensen after him, just a reminder to our reporters to raise your hand if you do have any questions, and I will turn it over to Joe Bruno.
Hello, Dr. Jacobs. How will COVID impact the rollout of violence, this violence intervention program, excuse me? And for Mr. Jones, what is the city investment in this?
So I'll be brief. That's an excellent question. Hospital-based violence intervention programs across the country are struggling with the impact that COVID has produced because they interrupt or interfere with the ability of the violence interrupter to meet directly with the families. We'll take the same precautions that we take everywhere else in the hospital. There'll be masking, there'll be social distancing, but there has to be human interaction. We know that if we miss that opportunity to have an interaction when the patient first presents, then we are not as effective at delivering that intervention. So the goal is to provide face-to-face interaction as soon as we possibly can after the violent episode. Subsequent visits may be done virtually, but I believe that initial contact really does need to be in person, but done safely.
So, Joe, to your funding question, a few things I'd like to frame for this discussion is that as a part of the Safe Charlotte plan, we have $500,000 that's set aside for this program. However, there's an additional $500,000 that is set aside for the violent interruption program, which is starting in the Beatties Ford corridor, in which the county is partnering with the city for that initiative. And those two together, we believe we'll have positive results. But also we've set aside $1 million for our grassroots organizations to help us in this quest to address violence as a public health crisis. So $500,000 across a couple of years for this particular program, but all in, we have about $2 million set aside.
Our next question will go to Ryan Pitkin.
Sorry. Yeah, I was actually just sort of wanted to build on what you just said there, Marcus, in terms of some of the multifaceted aspects of this. And I guess this can go to really anyone involved in planning, maybe Larkin as a member of the Safe Communities Committee or Dr. Jones. But just in terms of working with these grassroots organizations, how tied in will the Atrium, the new violence prevention office at Atrium be with some of these grassroots organizations? Will it be equal to how you work with caseworkers, whether that be, like you said, some aspects earlier to do with legal cases or things like that? will there also be working with community on the ground activists who, in terms of literal violence prevention, in terms of stopping incidents from going any further?
So, thanks, Ryan. I think undoubtedly we want, and I think the Cure Violence model in particular, we're going to be looking to utilize people in the community who have a really deep understanding of the unique people and places and challenges that we have in our city to intervene in some of these violent situations. I think Dr. Jacobs can speak maybe more specifically to how their program will integrate people here in our community who might be the activists or the community experts and people who have that trust built up amongst their neighborhood specifically. But undoubtedly with the Cure Violence model and the violence interruption program that we're working on more in the neighborhoods than in the hospitals, we will absolutely be utilizing those folks.
Yes, I believe that it's going to be vital for us to work with Cure Violence and any other community organization that can provide the kinds of services that our patients are going to need. The Cure Violence model is really built on having individuals who understand the community, who have credibility in the community to help get to the bottom of whatever caused the violent incident. And I think from a hospital perspective, our violence intervention workers need to have that same understanding, that same credibility, that same knowledge of the community so that they can be in the best possible position to help the patient. So we recognize that we, as a healthcare institution, we can't provide many of the services that I mentioned earlier, but we can certainly partner with those organizations and make sure that those services are delivered in a way that makes sense and recognizes the unique risks and struggles that the patient presents.
Courtney Cole.
Good afternoon. This question is anybody involved with the city. Just curious. I know you all said this is a first of its kind program, and just last year in 2020, we saw homicide numbers that were higher than we had seen in years at this point. And while starting this new program, I guess, what are some things that you all are considering with getting started and trying something new, but also your hopes for it, not just this year, but in years to come and also throughout the rest of the state?
So I think the best way to address that question is that the city and the county, as I mentioned earlier, almost 2 years ago, developed this joint violence prevention framework as violence is a public health crisis. So just having the partnership with the county to split the costs of some of these programs, but also to have one strategy that both the city and the county are deploying at the same time is important. The other thing that's important is that what we're talking about today, and I know homicides have come up, we aren't looking at this as just a policing effort to address the homicide count or to address violent crime, but we're trying to look at this in a very different way. And as we go back to the Safe Charlotte report, as you will see, it is how we have our neighborhoods, how we have jobs, how we have housing. All of that really points us back to opportunity, equity, and safety. So I believe that having partners like Atrium, having partners like the county, and having some of our nonprofits working with us is a very different way of trying to address violence than what we've done in the past.
Brett
I just want to,
Jensen.
can I add something to that? I think that I often use this phrase, I often tell people that my mother said, watch my feet, not my mouth. In this case, what this means is we have to have sustainable funding for these programs. These are not programs that we're going to implement and start without thinking about what do we do to measure the results. The council's very clear, good metrics, innovate, change, and finance. We need to do all of that, and that's what the city council has committed to do.
Our final question of this afternoon will go to Brett Jensen.
Thanks. I guess this might be for Larkin or Dr. Jacobs. Larkin, from the terms of the city standpoint, have you guys reached out, or is this purely independent of CMPD and the Sheriff's Department, or have you reached out to them to try to get any guidance, or Dr. Jacobs, or are you guys just basically going on and getting help from the other 40 programs across the country that are like this? Or will any law enforcement be involved with this, either on an advisory board or helping one way or the other?
Yeah, I'll let Dr. Jacobs answer this as well, but everything we do around community safety is going to be done in partnership with our law enforcement agencies. That's always going to inform the approaches that we take, whether they're involved directly or indirectly. They're always going to be a part of that conversation. And I know Atrium has worked with CMPD before, so this won't be the first time that they're partnering in that way. Dr. Jacobs.
Yes, we do have a steering committee that's composed primarily of clinicians within the hospital and folks who have interfaced and have experience interfacing with victims of violence. We also have a relationship with the Health Alliance for Violence Intervention, which is essentially the organization that oversees and coordinates these 40 programs across the country. They're going to be very, very heavily involved in helping us make sure we get this launched in an appropriate way. The issue of law enforcement is a difficult one. As you can understand, many of these victims of violence are somewhat hesitant to come forward with law enforcement because of the history of that. We're sensitive to that, but I think the relationship that is built between the violence intervention specialist and the patient really does need to be confidential. And that's the only way that we're going to be able to build the kind of trust that's necessary to make sure that this program is successful. So we are certainly not endorsing shutting the law enforcement community out of this. They need to be involved in the larger violence prevention efforts throughout the city. But for the hospital-based component, it'll primarily be our violence outreach workers and our hospital clinicians.
Dr. Jacobs, thank you so much for your time today. We appreciate you joining us, along with all of our reporters for joining us and asking some great questions. We hope you have a great rest of your day. Thank you, everybody.